Okay. Okay, hi everyone. Welcome to another section of Dental Shadower, and today we're very happy to have Dr. Mustelier with us today. And thank you so much for taking this opportunity and give a talk to all the students pre-dental students out here. And yes, you can take it away whenever you're ready.
Awesome. Thank you so much for having me. As you mentioned, I'm Dr. Jessica Mustelier. I'm a general dentist and implantologist. I work out of Miami, Florida. Just a little preview of what we're going to do today. We'll go into a little bit of my background, what I do. We talk about my office. I specialize in mostly implants. So we'll talk about diagnosing for an implant, and then we'll go into some cases. So let's see. All right, so this is my son. His name is Jagger, and we'll go into my education. I graduated from the University of Florida in 2005 with a Bachelor's of Science degree in chemistry. While I was at Florida, I was part of the Pre-Dental Society. I also worked in the organic chemistry department and participated in undergraduate research that had to do with cinnamaldehyde and GCMS, which we presented at the Pittsburgh International Conference, and it led to a publication in the Journal of Chemical Education. I graduated in 2013 from Miami-Dade College with an associate's in dental hygiene. While in the hygiene program, I was vice president and president of the class consecutive years. I was president of the Honor Society. I was selected as the student delegate for our district. I was also part of the All Florida academic team and selected by the faculty as the most outstanding graduate. My dental school was Lake Erie College of Osteopathic Medicine, which is located in Bradenton, Florida. I graduated in 2009 with my D&D degree. And at LECOM, I was part of the Hispanic Dental Society. I was a student mentor, which meant that any incoming student, a freshman student, I would help guide them and get their footing into dental school. I was also a peer tutor. Mostly I focused on tutoring perio, but I could also focus on anatomy, dental anatomy, any other clinicals also. I participated in various research projects, including calcification of the stylohyaloid ligament in the LECOM patient population, nutritional projects, and an investigatory paper on cemento osseous dysplasia. I was given the Dean's Award upon the graduating class, which is only given to one student. I also obtained the Student Merit Award and an Academic Leader Award. So let's see, my path to dentistry, which is not straight. It was more of a winding road. Dentistry had always been my dream. So ever since I can remember, I wanted to be a dentist. The reason was that I thought dentistry was an incredible profession. I was always heavily science-based growing up. I always excelled in sciences, excelled in the maths. So I always wanted to be in the medical field. And the reason that I chose dentistry was because I thought that dentistry had an amazing work-life balance. You were a doctor, you had a great career, but you could also have time for yourself, time for a family. So when I graduated in 2005 from UF, I actually didn't go right into dental school. I had the opportunity to teach at a middle school. My brother's girlfriend at the time, her mom was a principal at a school, and she was kind of recruiting me like 6 months before I even graduated. So I went straight into that. I taught middle school science for 2 years. At the end of the 2 years, I realized, this isn't what I want to do. I want to continue on the dentistry path. And I left and became a surgical assistant at a periodontist office. While I was there, I was actually recruited by the Centers for Disease Control. One of my professors that I did research with at UF, he was now at the CDC, and he reached out to me and told me that the research I was doing at UF coincided heavily with the research that they were doing. At the CDC, I worked in the emergency response and air toxicant branch, part of the NHANES project, which stands for National Health and Nutrition Examination Survey. The NHANES is how we determine our growth, height, weight charts. And how it works is they take a subset of the population in different cities, and the subset is supposed to represent the US population. Specifically, my task within the team was to analyze water, blood, and urine samples for what we call volatile organic compounds. We analyzed them for like 57. Mostly the five really important ones were like benzene, toluene, O-toluene, 2,5-dimethylfuran, and there was a few more. On a side, we were also part of the emergency response, which meant that if there was a natural disaster, a terrorist attack, some sort of issue, we would send a plane out, collect samples, and bring them back to the CDC in Atlanta and run the samples 24 hours to determine what was the cause of any issues that people were having. This could be cyanide, it could be a chemical spill. It was a slew of things that we would analyze for. So I worked at the CDC for about 3 years. At the end, my husband was actually transferred back to Miami. So collectively, we decided to return to Miami. And as soon as we went back to Miami, I enrolled right away in the dental hygiene school because it had been quite some time since I graduated from UF. So I needed to take my DAT. I needed to update some of the classes. So I did that while I was at the hygiene school. I had my son in 2013, the semester right before I graduated hygiene school. And once he was born, I studied for the DAT, worked part-time at the dental hygiene school, as well as part-time as a hygienist. I ended up getting a 29 and a 28 respectively on Orgo and Gen Chem, which kind of makes sense because I was heavily a chemist. And then I started dental school in 2015. So applying to dental school, every application becomes more difficult, more competitive. It's not really enough to have straight A's anymore. It's not enough to have a solid, DAT. You really want to stand out. Almost everybody has an A average. Everybody's doing 20s or 21s, 22s on the DATs. Some people are even getting 30s on the DATs, which is a perfect score. You want to stand out. How do you stand out? Be involved in your school, be involved in dentistry, like go to a dentist office, shadow, really make yourself stand out. Show that you actually want to be involved in dentistry. You want to develop your hand skills early. Ways that you can do that is pick up a hobby. Do you like to paint? Paint on the weekends. You can knit, you can sew, you can play an instrument. For example, I've played piano since I was 5 years old. For a while, I was also playing violin. So all of these little things, even though they seem minor, they help develop your hand-eye coordination and your visual spatial relationship. I also want to mention, don't get discouraged if you don't get accepted in the first application cycles. There's a limited number of dental spots available. There's not a lot of dental schools. So we have thousands of applicants for a limited number of spots. But if dentistry is your dream, keep at it. Don't ever give up. So always find a way to make it work. Continue adding to your resume. So how do you add to your resume? Take more classes, reach out to a dental school that you want to go to, see how you can make your application stronger. There's also something called a master's in biomedical science, which basically cover your first 2 years of any medical school or dental school. You're taking anatomy, basic sciences. And if you take the Masters of Biomedical Sciences at some schools, they even credit those classes and you don't have to retake them once you enter dental school. All right, so my specialty. So I kind of gave you a little snippet of it. I'm an implantologist as well as a general dentist. So what that means is I don't have a specialty degree. I have a degree of general dentistry, but I've focused my practice in implantology and the placement of implants. So I do all of the procedures that relate to implants, from extractions all the way to the implant placement to putting the crown on the tooth. I like this because I don't only have to focus on the surgery part. I can see my patient from the beginning of treatment all the way to the end. And patients tend to like this because they don't have to go from office to office. They don't have to go to a different practitioner. Once they feel confident at an office, they don't want to leave. They have a special relationship with their practitioner, with their doctor, and they like that I can provide the entire care here in my office. Some of the procedures that I do on a daily basis include extractions, bone grafts, ridge augmentations, which means that the bone is too thin and we have to grow some. But I can also help them out if they need fillings or crowns, if they want to do clear aligners like Invisalign. We can do all of that here in the office. So I work at Implant Center of Miami. It was created by Dr. Herzog. She's here in the middle. I'm over to the right. And we have several offices across South Florida. There's the main one is in Bay Harbor Islands, Coral Gables, which is where I'm at, and Sunrise. And then there's more to come soon. We also opening one in Coral Springs. Implant Center of Miami was really a perfect fit for me because I wanted to be in a surgical aspect. So during dental school, I really loved surgery, but I couldn't decide on what I wanted to specialize in. And I graduated and I said, well, let me just go into general dentistry and see if I can focus while I'm doing all of these different procedures, what my skills are leading me to. So while I practiced my first year, I found that I really enjoyed surgery. So when I met Dr. Herzog, she had the opportunity and she had a new office opening up, and I really jumped at the chance to work with her. Dr. Herzog is a board certified implantologist. She's been placing implants for over 10 years. She placed about 1,000 implants a year. She's incredible, and she's really taught me all that I've known. When you graduate from dental school, you also have an option to work in private practice versus corporate. Both have their benefits. Corporate dental offices usually tend to take a lot of new graduates to help them develop their hand skills, because when you get out of dental school, you're not as fast as you will be a year, 2 years, 3 years down the line. And they take the time to really train you. They give you the time that you need. Private dental offices tend to run a little bit faster. They're a little bit more faster paced. But you really need to see what fit works for you. You need to look at several different factors when applying for jobs. Do you want to mentor? Is there a mentor at the office that will help train you in what you want to learn? Those are all important things. Are they a digital office? Are they paperless office? Are they using traditional impressions? Are they using digital impressions? There's a whole slew of things that you have to look for when applying to jobs, and you want to make sure that they align with your goals for the future. So this is my team at the Coral Gables office. We're here celebrating Addie's birthday. She's here in the middle. There's only one doctor here most of the time, which is me. Dr. Herzog comes every Wednesday, and she really does the more complicated procedures. We have 4 assistants, 1 part-time hygienist, an office manager who also doubles as my treatment plan coordinator, and 2 front office, and I have a backup treatment plan coordinator just in case we get a little backed up. I have 6 operatories, which 6 treatment rooms. 2 of them are surgical suites, 3 regular patient rooms, which we see new patients, fillings, crowns, 1 hygiene room. We also have an x-ray room that has a panoramic x-ray, which can double as a CBCT. And we have what's called a Nomad, which is not the traditional way of taking x-rays. It's a portable x-ray machine. The radiation is much less, and you can actually get much better angles than the traditional x-rays that you are used to seeing with the arm. So schedule. A typical day at my office, we see a variety of new patients, surgical patients, and post-operative patients. I like to run my schedule with what are called schedule blocks. And this means that patients are coming in at different times. The reason that we do this is because I'm only one doctor and I can't see 5 patients at the same time. So typically what I do is I'll see a new patient on the hour. So let's say 9 o'clock, then I'll have a surgery patient come in at 9:30. And while the surgery patient is getting numb, then we'll see a post-op patient deliver a crown, anything on the 45 of the hour. The way that I like to do this is because it helps me flow through the day much easier. And I'm not stressed out, oh my gosh, these patients are waiting for me. It helps us stagger the patients. The patients aren't waiting as long, which patients don't like to wait too long in the chair. We also have room and assistant assignments, which helps, organize and keep the schedule flowing. And the goal is really to have as minimal downtime as possible. You want to be bouncing from room to room and keep the day flowing. We see a combination of new and surgery patients, everything in between, and we run our office more like a surgical specialty office. So we really depend heavily on an influx of new patients. Something that I really want to mention is at the beginning of every day, we do what's called a morning huddle. This is the time to go over the schedule with your team. They can tell you anything special. You can tell them if you need certain instruments for a certain procedure, if cases have arrived, if cases haven't arrived, and anything in between. I also like to end the day with, or end the huddle with a motivational a motivational quote, and then we discuss the quote at the end. You also want to take time for lunch breaks. So even though you want a consistent flow, you really need to take a break for yourself, because back-to-back patients can get tiring. So you need that mental break. Just step away, grab a 5-minute, 10-minute, 30-minute lunch break, whatever you need, so that you can come back to the afternoon patients refreshed. You also need time at the end of the day or in between patients to write your clinical notes. Okay, so how do I diagnose an implant? A lot goes into it. It's not just, okay, yeah, you're missing a tooth, you can get an implant. No, it's much more than that. So the first thing we do is take a set of x-rays when the patient comes in. And before I even walk in the room and introduce myself to the patient, I look at their x-rays. I look and kind of have an idea of what's going on before I walk in the room, and then I address their chief concern. So the type of x-rays that we take are a panoramic x-ray, always on every single patient. And sometimes we'll take periapicals or bite wings, depending on what we see on these x-rays. We also take a CBCT, which is a 3-dimensional image. The reason we take a CBCT is because our bodies are not 2-dimensional. We need to know how much width of bone, how much height of bone you have. And we want to make sure that where we're planning to place an implant is not near any major structures. So after I look at the x-rays, then we do the clinical exam. We need to evaluate how much space the patient has. Does the patient have enough space in between the teeth to place an implant? Or has it been so many years that they lost a tooth that the teeth have now closed that space? We also want to look at the bite. When the patient bites down, is there enough interocclusal space? Because I can put an implant in the bone, that's fine. But we also need to see how much space I have for the crown, and the minimum amount of space needed is 5 millimeters. So if I don't have 5 millimeters, we need to figure out how we're going to get that 5 millimeters. We also look at the gingival tissue. So around the implant, you want to have healthy keratinized tissue. You don't want to have thin mucosa, because it's not going to give the implant the support that it needs. So if you have this mucosa, we have to figure out, are we going to do a gingival graft as well as the implant, or are we going to kind of do a special procedure during the surgery to get that keratinized tissue? All right, so let's jump into the cases, which I think everybody will enjoy. First, we're going to go into a stepwise implant placement. Then we'll talk about extraction, a different type of implant procedure called overdenture. We'll talk about white spots, veneers, and extractions, and then we'll do a really interesting case that I love about a deficient alveolar ridge. I do want to tell you that some of the upcoming images may be considered graphic. So first, a stepwise implant placement. So this patient came in, he wanted a premolar implant because he was missing tooth number 5, which is right next to the canine. First thing, I'm going to look at the CBCT and I'm going to look at the pano. So this is a cross section of the CBCT. And I'm going to be measuring the width of bone as well as the height of bone. So here the width measurement is 6.21 and the height is 22.40. So how do we know? Is that enough? First, we have to talk about implants. So implants come in all widths, all heights. The most narrow implant that I carry here at my office is 3.3 millimeters, and the widest is 5 millimeters. So it's not enough to have just 3.3 millimeters or 5 millimeters. And you need to have at least 1 millimeter of bone in front, as well as 1 millimeter of bone behind the implant. Why? Because this will prevent the body from resorbing the bone in front or the bone in back and give good stability to the implant. So this patient has 6.2. Usually we don't place narrow implants, which are the 3.3s, unless it's like a lateral incisor. So the next size up is a 3.75. So the patient has 6.21, 1 millimeter in front and 1 millimeter in back. That's 5.75 that I need. So this patient obviously has enough bone with 6.21 millimeters. The height of the implants come from 6 millimeters all the way to 16 millimeters. So this patient has plenty of bone. We can absolutely put an implant in here. So once we get ready for the implant, your implant kit has a variety of drills. Some of them are to start the surgery, some of them are to deepen the site, and some of them are to widen the site. So first, you want to decide where you're going to place your implant. So you don't want to be too close to the teeth. You need to be 1.5 millimeters on each side. The reason is that if you're too close to the tooth, you might have some bone loss and you might have some sensitivity around the natural teeth. Implants don't have nerves, so they're not going to feel anything, but the bone and the teeth around it can. So you need 1.5. You want to try to get the implant as centered as possible. So you do your initial drill, and then you can stepwise increase in height. So we started here at 6 millimeters and went to 8 millimeters and 10 millimeters, which was going to be the final length. Once you get to the final length, you widen what's called the osteotomy, which is the hole that the implant is going to be placed to the width that you want. And here we have the final implant placement. And one thing that I want to mention is that you want to always make sure that your cover screw is seated all the way, because if not, you can get an inflammatory process around the implant. You can have some invagination of the epithelial tissue, which can cause some issues. Right, so next we're going to talk about extraction and then implant. So this patient had a tooth that was heavily infected. And the way I know it's infected is around the roots of the tooth, you see this dark circle. And he needed an extraction. This tooth was most likely fractured because he had a root canal previously. Root canal teeth over time, sometimes they fracture, and root canal teeth also have something called a J-shaped lesion, which we'll get into a little bit later. So we ended up extracting this tooth and placing a bone graft. There's different types of bone graft, all from autograft, which comes from your body, all the way to xenograft, which is an animal bone. Typically, what I use is freeze-dried allograft, which is cadaver bone that goes through these different chemical and irradiation processes. And they really much act like a scaffold for your body to incorporate native bone. So once I extracted the tooth, we cleaned out the socket and we placed the bone graft. This is a cross-section of the CT scan a few months later, and the bone graft wasn't ready yet. Typically, it takes about 3 months for the bone graft to integrate with your own bone. But when there's a large infection, it can take up to 6 months, maybe even more. So when I took the CT at 3 months, I said, okay, well, the bone isn't integrating as quickly as I wanted. How I can tell is that there's a lot of dark spaces. It's not solid white. So we let the patient heal for 3 more months. So a total of 6 months healing prior to implant placement. After 6 months, we placed the implant. And once I went in and placed the implant, the bone was still a little bit soft. So we also waited 6 months before we restored this implant, leading to a total healing time of 1 year. This next case is a case that I did recently. It's called an implant-supported overdenture. Overdentures can also be tooth-supported. And an overdenture is a removable dental prosthesis that covers and rests on one of more remaining natural teeth or implants. And there's a picture of an overdenture down here. So a patient came in. He had been wearing dentures for years. He wanted something different, and he wanted to be able to taste his food. So when you have a denture, especially on the top, your whole palate is covered. So your pressure on your temperature and your taste is all altered. He really wanted to be able to taste food again. That was his chief complaint. So we decided to do an implant-supported overdenture with 4 implants. So this is how I plan for the implants. I like to place them, in certain locations. For overdentures, it's crucial that they're all straight. You can only have a 15-degree difference. If not, they won't be stable and they'll be popping off. Initially, we had plans for 4 on top and 4 on bottom. And here's the post-op CT. So you can see that they're really parallel. And we ended up only doing 2 on the bottom because clinically, when we got in there, the inferior alveolar nerve exit was a little bit closer than we liked. So we put 2 for now. We might go back and do a 3rd one depending on how he feels once he's healed. And here's a surgical picture. So from this angle, you can really see how parallel the implants are. There's another procedure called all-on-X, which means you have an implant-supported prosthesis, the X is depending on how number of implants you need. The minimum is 4. When you have an all-on-X procedure, you don't need the implants to be as parallel. The reason is that you have what are called multi-units to correct any position. And your denture is going to be attached to these multi-units and they're fixed. They're never going to come off. With an overdenture, you're going to have locators coming out of the implants, and the patient has to snap on and hook on their denture. So you really need to have them straight so it's easy for them to put on. And when they're eating, they're not wobbling and knocking out their overdenture. This next patient had white spots. She was born with these white spots on her teeth. She's had them her whole life. We decided to do a very minimally invasive treatment called Icon Infiltrate, which there was no drilling involved at all. And it's a treatment fabricated specifically for white spots lesions. And how it works is you get a very strong etch, which is an acid, and you place them on your teeth. And you do this in several rounds. I think with this patient, we did 4 rounds, and it basically makes the white spot disappear. Once you are happy with the way that the tooth looks with the etch, you cover the teeth in an unfilled composite or like a tooth colored material that mask the little porosities from the etch. So this is how we ended up. And the patient was very, very happy. Something simple, but life-changing. Next, we have a veneer case. So veneers are very popular. They're aesthetic, and they're a thin or composite shell that covers the front of the tooth surface. Most of the times I tend to wrap it on the lingual, because if you just leave it on the tooth, they tend to pop out, especially if somebody's a grinder. And something that I want to mention is that veneers are a permanent change to your tooth. So we can correct minor imperfections like some spacing, some crooked teeth, but we can't correct like huge gaps. We can't, if the tooth is really inverted or extruded, we can't correct those, but minor imperfections we can definitely fix with veneers. All the veneers that I do are porcelain veneers. So I had a young girl come in. She had a very beautiful girl. She was very self-conscious about the way that her teeth looked because she was born with these spaces in between her teeth, and her lateral incisors were a little bit smaller than the rest of her teeth. So we decided to have 4 porcelain veneers in the front to even out her smile. These are the preparations. So with the veneers, you do very minimal preparation. You don't want to go all the way through the enamel so that you can have a strong bonded cement. So you just take like a millimeter off of the front. And here is the day of delivery. So the patient was in temps for a few weeks, and the temp usually caused the gum tissue to have an inflammatory response because you can't clean them as well. But we did the 4 in front, evened out her smile, and the patient was very happy. So extractions. So extractions come in all shapes and sizes. Some extractions are really easy. Some are very difficult. Sometimes the tooth are infected, fractured, all different. So we're going to go into 2. Each type of extraction has a different methodology that you want to follow. So the first one is a very deep cavity on a multi-rooted tooth. So it's always important before any type of surgical procedure to prepare. You want to look at the x-rays. If you have a CT scan, you want to look at the CT scan. So on this tooth, I could see there's a very large cavity. There's not really much tooth structure left. The cavity is taking a little bit more than 50% of the tooth. So we decided to go ahead and do an extraction. On the x-ray, I can see that this tooth has multi-roots, which is more than 1 root. And it's typical of a maxillary molar. Usually they have 3 teeth. So 1, 2, 3. And you can see that these roots are pointing in all different directions. There's, one's going one way, the other one's going the other way. So this tends typically to make for a difficult extraction. Usually I'll section a tooth like this. The patient didn't want me to section it. He wanted me to try to take it out whole. So patience is key. You really want to slowly luxate the tooth. Luxate means that you're moving it, you're separating the PDL, which is the periodontal ligament, and you can't rush this. If you rush this, the teeth are going to break 100% of the time. So you have to be patient. And with a little patience, I was able to get the tooth out whole. The patient was very happy. And when I look at the tooth, guess what? It had 4 roots, not only the 2. Right. Next, so vertical root fractured teeth. Usually a vertically root fractured tooth is one that has been endodontically treated. And the definition is a root fracture longitudinally oriented through the roots that originates from the apex and goes up to the coronal part of the tooth. So I had a patient come in, he knew his tooth was infected, he knew it was broken, he wanted to take it out. I had previously mentioned a J-shaped lesion, and you can actually see one here. That whole gray spot is an infection, it's an abscess. And on the picture on the right, you can actually see the shape of the J. It's like an inverted upside down J. Those are, if every time I see that, I know that that tooth is fractured. It's indicative of a vertical root fracture. So we planned for an extraction. Something that I noticed on the CBCT is that the infection was very close to the sinus. So you might not think that's a big deal, but during the extraction, you have to clean out all of that infection. You can't leave it behind. If not, your bone graft isn't going to take. So you have to be careful not to perforate into the sinus when you're cleaning out the infection, because if you perforate the sinus, depending on the size of the perforation, you can end up getting what's called an oral antral communication, which means that the sinus is communicating with the mouth. So every time they breathe, they could be filling their mouth with air. And that could lead to a whole slew of problems. So we took out the tooth. Here on the left, you can see the vertical root fracture extending from the root of the tooth all the way to the coronal portion. And the picture on the right shows the size of the abscess. This was actually just a little part of the abscess. When I was cleaning out, I could actually see the sinus membrane, which is called the Schneiderian membrane. I could see that blue hue. So I was very, very gentle, and I was able to get most of the abscess out together. And then the little sticks coming out of the crown of the tooth are just posts that they used to reinforce the crown. So there's a vertical root fracture. All right. And so this last case is one of my favorite cases. The patient came in, she had a trauma when she was young. She lost her front tooth, had 2 previous failed implant attempts. And she came to me, she's like, "Doctor, you're my last hope. I really want an implant. I don't want to use anything removable. What can we do?" So the first thing I did was take a CBCT. And when I measured it, her bone measured 2.8 millimeters, which was very thin, much thinner than my thinnest implant. The height was okay. This was a front tooth, and something interesting about the front teeth is that we have a nerve right in back. So we have to be careful. We're replacing that nerve, or the implant, or we can cause paresthesia behind the teeth. So I told her, we're going to need to build bone before we actually place the implant. And we did what's called a ridge augmentation, which we completely reflect the tissue back. On the bone, we make osteoperforations. They're little holes in the bone, which cause bleeding. And to induce the bleeding is actually very important, because bleeding is how the body heals. That's how we get the antibodies to places. If the bone is not bleeding when I make the osteoperforations, then the bone graft is not going to take. It doesn't matter how much bone I put, it won't take. So you have to make your osteoperforations and then stop what you're doing and look to see if these osteoperforations are bleeding. We also do something called PRF, plasma-rich fibrin, which we use the patient's blood, spin it in a centrifuge, and use the plasma to make membrane. We mix their plasma with the bone graft, and this helps in the healing process. So the second cross-sectional view is right after I place the bone graft. So you can see I've more than doubled the width. Now, I know that not all of this is going to stay. I want the majority of it to stay, but I at least need 2 millimeters, maybe 3 millimeters of bone to stay so that I can put an implant. So after the procedure, we had about 7 millimeters of bone width. We waited 6 months for the bone graft to integrate with her own body. We want to make sure that that bone graft is hard before we go in. And when I place my implant, I'm not going to place my implant in my graft. I'm going to place my implant in her native bone behind my graft, so that the graft is acting as support for the implant. And this is her implant after 6 months. Now, because we had to build so much bone, we're also waiting another 6 months before we restore her implant. We haven't restored it yet. We should be restoring it next month. So the procedures that we did for her were ridge augmentation. We gained about 4 millimeters of bone, which is quite a bit. And we waited 6 months in between each procedure. And that pretty much sums it up for me. I want to thank DentalShadowers for having me speak to you guys tonight. You can follow me on Instagram at Dr. Snow Whitening. You can follow Implant Center of Miami. If you have any questions, please feel free to reach out at me anytime. The best way is through my email. I don't really check the Instagram email very much. And my email is dr.j.mustelier@gmail.com. And then I'll hand it over back to you guys.
Okay, thank you so much for the presentation. It's very helpful, very detailed. And now we'll have some questions from the pre-dental students.
Yeah, so thank you so much, Dr. Mustelier. So from the YouTube chat, we have some questions. Our first one is applying to dental school in July too late?
No, I don't think it is. Obviously, you want to get in your application as soon as you're ready, but it's best if you don't have all of the parts of your application ready. In my opinion, it's best to submit them all at the same time. When I applied to dental school, I submitted everything in August. You might not get an interview till January, and that's okay. So July shouldn't be too late.
Awesome. Our next question is, do you have any advice for incoming college freshmen who want to pursue a career in dentistry?
So definitely take all of your prerequisites, look at the schools that you want to apply to, and make sure that during your undergraduate, you're taking those classes, even if it doesn't coincide with your major. I believe that a bachelor's in sciences are going to get you the most prerequisites without having to take extra classes, but it's not required.
Awesome. Our next question is, how did you know you wanted to be a dentist?
Oh, it kind of just came naturally to me. My mom growing up, we would go to the dentist every 6 months, and I loved going to the dentist. I had such a good experience. I actually saw my dentist at a meeting a couple of weeks ago, and I told him I became a dentist because of you. I think it really stemmed from just my joy of going to the dentist and seeing how happy everybody in the office was, how happy I was every time I went over there. And also, I wanted to be in the medical profession. I love teeth. So medicine and teeth led to dentistry.
That's awesome. Our next question is, what are your thoughts on taking a gap year before dental school?
I think gap years are amazing. I think you should, if you want to take a gap year, you should. You should also focus on maybe going to a dental office and seeing if that's what you want to do. You don't want to all of a sudden jump into 4 years of dental school without ever having stepped foot in a dentist's office. You might not like it. And that's okay. Dentistry is not for everyone. And there's so many different types of dentistry. You really want to go look at every single type of dentistry. There's general dentistry, there's orthodontics, there's periodontics, there's oral surgery, there's implantology, there's a whole slew of dentistry. I also think gap years are really good if you need to make your application stronger, help find yourself. Once you're in dental school, you need to give dental school your 100%. It's not like undergraduate. It's not like high school. You need to be there present 100% of the time. The reason is that this is what you're going to do for the rest of your life. You need to pay attention. You don't want to slack off. You need to remember everything that you're learning pretty much.
Our next question is, what is your favorite dental procedure?
Ooh. It kind of changes, I think, on on a weekly basis. I love doing extractions. To me, extractions are like a puzzle because every tooth is different, and some of them are very simple. Sometimes I can take out a tooth in 2 minutes, and other times I have to really think. I had both of those today, and the procedure right before this presentation took out the teeth in 2 seconds, but the one earlier today probably took me 30 minutes. So it's really like you have to get the pieces of the puzzle together in order to get the tooth out without any trauma to the bone, without causing any extra trauma to the patient.
Awesome. So our next question is, how many years did it take for you to get to where you are now?
Well, let's see. I graduated in 2005 and we're in 2021. I've been practicing for almost 3 years, so quite a bit of time. But I would say as far as my clinical skill, it's probably taken me like a year and a half to get where I am right now. And I still have much more than I want to grow. So dentistry is a profession that you're constantly growing. You're constantly fine tuning your skills. There's still a slew of surgical procedures that I want to learn that I haven't yet. And I will eventually. I'll learn I'm going to do tissue grafting and sinus lifts. Keep learning and keep, just tuning in your skills to what you like.
Beautiful, thank you. So someone's asking, is being a dentist hard?
I don't think being a dentist is hard because I love it. I get so excited to come to work every day. And it's not only the dentistry itself, I love being able to help patients. So the patients that come to my office, they've been to other offices and they can't do the treatment for whatever reason at the other offices. And sometimes I'm their last resort. And I love being able to help realize what the patients want. I love helping them smile again. I love helping them feel comfortable. I talk to my husband about dentistry and it's not the same. So, it's not hard for me. Are the days long? Absolutely. I've been here since 8 o'clock in the morning and I finished like at 6, but to me, it's worth it because I didn't even know it was 5 o'clock until my front desk is like, you have your presentation in a little bit. So.
So someone's asking, what is the hardest dental procedure?
So I think it depends on your clinical skills. So for me, the most difficult, I would probably say, are root canals because I don't do them every day. So root canals are a very delicate procedure, which means you have to take out the nerve of the tooth. The way that you do that is with like these little tiny files, which are very delicate and could break inside of a tooth. So to me, those are the most stressful procedures because I don't want to break these tiny instruments inside of a tooth. Do I do root canals? Absolutely. But it's definitely, for me, it's the most time consuming because I'm so focused because I don't want anything to go wrong in these procedures. And they take me the longest. They probably take me about an hour, sometimes longer if it's a molar tooth.
So another question is, how many dental schools did you apply to?
So I was what's called a non-traditional student, which means that I didn't go from undergraduate straight to dental school. I was married. I had a son. So my choices in dental school were very limited. I think I only applied to 3 dental schools, 2 in Florida, and I think 1 in New York. I only applied to places that I knew my husband could work from.
Someone's saying, what don't you like about dentistry? Or is there anything at all?
No, I mean, sometimes there's challenges, just like with everything. I'm sure school that brings challenges too. I don't like any, like there's everything. I love everything. Like, people managing is very hard because it's not only you just doing dentistry, you have to work with the patient. Sometimes the patients have their own issues that you have to help them through. You also have to work with your assistants and the managers. It's like a whole team effort. It's not only you and the dentistry. So that's probably the most challenging part, but I still love it. I love working with my team. I love working with the patients. It's all fun.
So we have someone in the chat asking, as a woman in the dental field, have you faced sexual harassment from patients and how have you dealt with it while remaining professional since it is very upsetting?
Mm-hmm. So not full-on sexual harassment. I have had some comments made towards me, but nothing I can't handle. I kind of just make a joke out of it and let the patients know that it's not appropriate.
That's a great answer. And I think we have time for one last question just to wrap things up. So if you're not practicing dentistry, what would you be doing?
Oh, I'd probably still be a chemist. Those are my two passions in life, chemistry and dentistry, but dentistry won. So probably chemist, yeah.
Well, thank you so much, Dr. Mustelier, and Joy. I'll let Joy do the closing.
Okay, yeah, thank you for answering all the questions. They're like, I love hearing about like your passion about dentistry. It's amazing. Hope you continue what you're doing, you know. And yeah, the quiz link is up, I believe, in the group chat and also in the YouTube channel chat, and fill them out for participation point. And I think, yeah, that's it for today. Thank you so much, Dr.
Awesome. Have a great night. Please feel free to reach out to me with any questions. I love hearing from people. And since I had such a long path to dentistry, I love helping everybody achieve their goals. So have a great night, guys.
Okay, thank you so much. Have a great night, guys.